Okay, here we're going to run through some common skin lesions we should be aware of. We're going to review primary morphology because it's a great organizational system. We're going to talk about skin cancers, keratoses, actinic and seborrheic, infectious lesions, cellulitis and dermatitis, and then varicose veins and peripheral edema. So let's review primary morphology. Again, this was a great organizational system for us. We have macules, which are flat, circumscribed skin lesions less than a centimeter in diameter. We see a freckle here. And then we have patches, which are again flat, but greater than a centimeter in diameter. A papule is a solid raised lesion that's small. A plaque one is large. Again, 1 centimeter is the distinguisher. This is a wart right here, and then this is a psoriatic plaque over here. So we can apply this to maculopapular rash and eosinophilic rash and DRESS syndrome. So this is eosinophilic, it's red. These lesions are small. They can be macular, they'll be flat, or papular, they'll be solid elevated lesions. Blisters, bulla and vesicles, these are fluid-filled lesions. Vesicles are small, bulla are large, again 1 centimeter as the distinguishing value there, and we can see these vesicles and bulla here. Nodules and tumors. Nodules are dermis lesions. They go into the subcutaneous tissue. They're generally 1 to 2 centimeters in diameter, whereas a tumor is a larger lesion, also known as a mass, but there's varying definitions for tumor as it applies to different body regions. And then we have urticaria, which are transient solid elevated lesions. Again, it's a intensely itching phenomena with serpiginous and circular formation with central pallor due to mast cell and basophil release of histamine and other vasodilators. So now some hemorrhagic lesions, ecchymosis, large extravasation of blood into the skin. Purpura here, non-blanching, violaceous hemorrhagic lesions. They can be flat or raised, versus petechiae, which are 1 to 2 millimeter non-blanching reddish lesions that are macules. They're flat. So we can think of petechiae as tiny flat form of purpura. So let's jump into skin cancers and moles. We'll start with moles here. So there are normal common moles. The key characteristics is that they're symmetric, they have a regular border, they have an even color, they're less than 6 millimeters in diameter, and they do not evolve over time. Now, an atypical, a dysplastic mole, again will be symmetric in color, but it will start to have an irregular border, which we show here. There's color variegation, meaning there's different zones of hues. We can see different zones of brownish hue here. They're still less than 6 millimeters in diameter, and they do not evolve. The important thing about atypical moles is that although they don't tend to transition into melanoma, if a patient has a lot of atypical moles, they have a higher likelihood of developing a malignant melanoma. So now let's discuss malignant melanoma. This is the leading cause of skin cancer-related death. The ABCDEs of melanoma, we have an algorithm on the side for this. Start with asymmetry. This means that the different halves of the melanoma can have very different coloration. Not a strong example of that here, but that is the reality. Border irregularity versus the even border of the mole. There can be color variegation, meaning there should be different zones of colors, and they can be drastically different colors throughout the melanoma. Greater than 6 millimeters in diameter, and it evolves over time. So we pointed a few of these things out here. We tried to demonstrate some asymmetry in the color for you here. There's border irregularity, and then we can see some different color variegation, different zones of coloration here, and then of course we show that it's greater than 6 millimeters in diameter. Basal cell carcinoma, the most common skin cancer, but only rarely lethal. Concentric shape, it has this papular formation, pearly pinkish hue, and it's shiny. And then there are these telangiectasias, this vasculature that we see here. We can see this example right here, the shininess showing up in these telangiectasias, these little vessels. Very locally destructive, can cause a lot of morbidity from local destruction, but does not tend to metastasize and is only very, very rarely lethal. Squamous cell carcinoma. So squamous cell carcinoma has an irregular shape, unlike the basal cell carcinoma. It's pinkish, it's a plaque, so it's elevated, and then it has these characteristic hemorrhagic crusts here. Here we show it with some ulceration there, and then here there's no ulceration, so you can appreciate it. A thing about squamous cell carcinoma is that immune suppression will increase the likelihood of cancer, of all types of cancers, but it especially increases the likelihood of squamous cell carcinoma. So the likelihood of squamous cell carcinoma is greatly increased by immune suppression. Keratosis, actinic and seborrheic. Actinic keratosis here, we can see that it's crusty, scaly. The key thing about actinic keratoses, and they develop in sun-exposed areas, is that they can be a squamous cell carcinoma precursor. This is in opposition to seborrheic keratosis. These are benign, they have this stuck-on appearance. They can kind of mimic squamous cell carcinoma in their appearance, but they're not squamous cell carcinoma precursors. Infectious lesions. So oropharyngeal candidiasis, thrush, we see this pseudomembranous exudative plaque here, this creamy white plaque, underneath an erythematous tongue here. If we scrape this off, it can easily scrape off, and we test it with potassium hydroxide prep, we'll see these budding yeast or yeast with pseudohyphae. Easily treatable, but typically are often asymptomatic, but can cause oral pain, especially with swallowing, and it can cause a loss of taste as well. HSV-1. So herpes simplex virus 1 can do a whole lot of different things. Here we're going to focus on oral labial ulcers. They're a reactivation of HSV-1 infection. So HSV-1 infects into the skin, it tracks along the sensory nerve, and then it lies dormant in the sensory ganglion. It can get reactivated under physiological or psychological stress, and then the infection will carry back down the nerve, back to the skin. So there's typically pain before the ulcer even shows up, here at the labial border right here. And then within a day, the vesicles will start to erupt, the pain will start to dissipate, and then the vesicles will crust over in 5 to 10 days and heal. Herpes zoster, on the other hand, shingles, very painful condition. The pain precedes the rash by 3 to 7 days here, and then vesicles develop over several days in a dermatomal distribution, most commonly the thoracic level or in cranial nerves 5 and 7, so 5 trigeminal, 7 facial. The important thing to know is that the facial nerve runs along with the vestibulocochlear nerve, the 8th nerve. So these two can sometimes be affected together. If they are, it's called Ramsay-Hunt syndrome. Patients are no longer contagious after 7 to 10 days of rash. Post-herpetic neuralgia is an important potential complication. This is ongoing nerve pain 90 days, 3 months after the rash eruption. Again, the herpes virus lies dormant within the dorsal root ganglion, and then it tracks back to the skin to cause this vesicular rash. In individuals older than 50, it's generally recommended they get the shingles vaccine. If you're older than 60, it's very strongly recommended you get the vaccination. Folliculitis, this is hair follicle infection. It can develop with papules, as we see here, these solid, elevated, raised lesions here, or pustules, which are pus-filled raised lesions. There's numerous potential microorganisms that can cause folliculitis, bacteria such as Staphylococcus, fungi such as Candida, viruses like herpes, and then parasites such as the mite. Cellulitis and dermatitis. So cellulitis is a really strong inflammatory response. There's skin injury, this cellulitic response kicks in, the skin is warm to the touch, it's erythematous and red and edematous. There's some red flag features with cellulitis you need to be aware of. One, septic shock. Another is rapid progression of the cellulitis. And then the last being pain out of proportion to what you see on the exam. All of those would urge you to push for rapid, aggressive treatment of the cellulitis. Irritant contact dermatitis. So here we have poison ivy causing this vesicular eruption. And then here we have a post-transdermal patch irritant dermatitis. There's a scalded appearance to the skin and it's very scaly. Venous stasis dermatitis, so sometimes the blood gets pools in the legs, such as in peripheral neuropathy, and over time the skin can change. So there can be hyperpigmented, thickened skin. The skin can have eczema. We see how reddish it is here. There can be varicose veins and even venous stasis ulceration here. So varicose veins and edema. Varicose vein, normally the vein has this nice one-way valve with good flow, but over time this can dilate and twist and develop this varicosity. We can see this varicosity right here, and these are all changes from varicose veins. Finally, peripheral edema, excess fluid volume, there's this translucency, this discoloration, and you can have skin sloughing. So that's a quick run through of common skin conditions. We reviewed some nomenclature for primary morphology, skin cancers, actinic and seborrheic keratosis, infectious lesions, cellulitis and dermatitis, and then we discussed varicose veins and peripheral edema.